last but certainly not least in this session is, thank you, Rachel Berrington, who's the Senior Diabetes Specialist works in University Hospital of Leicester, and she's led the multidisciplinary foot clinic there for the last 10 years. And she's also doing a master's at the present time in advanced nursing practitioner, and she's going to talk to us about the expanding role of the diabetes foot specialist nurse. So welcome to Malvern.
Thank you, first of all, for the opportunity to speak today. And a bit like Jodie, I was a little bit, now what do I cover in this talk? Because actually, there's probably not many nurses here, and I'm always very mindful when you come to a foot conference that there is a minority of nurses. So when I talk about the expanding role of the nurse, please be mindful that I think within the MDT, our roles are more blended now than they have ever been, and we do a lot of cross-boundary working. So it's not necessarily a nursing role in some of what I'm talking about. It could be you or not. So I first had the opportunity to come to Malvern in 2014, a couple of years ago. And it was the first foot conference that I ever attended. And you can see I've added a sunshine there. And after today's rain, I'm hoping that we're going to get some more fine weather. And it was actually a glorious time. But it was the first conference I'd ever attended. I'd been a diabetes nurse at that point for about 12 months. And I had a bit of a 12-month plan of upskilling, getting to know about diabetes, 5 years down the line, moving on. Clearly that didn't quite work out. But when I came to the conference, I was able to put names to faces of articles that I'd read and actually put them as a human being. And when I listened to them talk and the passion that they had, it truly did inspire me. And I went away questioning some of what we did clinically and thought, we could do that better. Some of it I thought, actually, we're doing as well as that. Why aren't we telling everybody what we're doing? And it really did inspire me to think about actually my career as a diabetes nurse and whether it's something I could work through. Clearly I did, and I learnt a lot from the presentations, but as Jodie alluded to, I also learnt a lot from networking. And I know that's not quite so easy in COVID times, but it can't be underestimated. So my 5-year plan didn't work out. I am still a nurse within the diabetic foot clinic, although my skills and competencies during that time have changed significantly. The thing that's always pushed me and driven me is to have the patient's outcomes better than they were. And I think that's the theme that's come through quite strongly this afternoon. But it is the one thing that has really been my passion. And I think being a trusted and respected member of the team helps that become more achievable. And I've always strived to do the best that I can. And I was fortunate enough to be awarded last month with the Cavell Star Award. So the Edith Cavell Star Award is something that's awarded to nurses and midwives by their colleagues when they go the extra mile. And I have to say, it's rare I'm stuck for words. However, this one completely floored me. But I think it was a nice way of actually being recognised by the team as to what we actually do and how we give this care month in, month out, not just at difficult times. So obviously I'm a diabetes nurse, but you'll be pleased to know it's not just all about sugar. So clearly what we do from a glycemic point of view is fundamentally important because we need to get good glycemic control to try and get good wound healing. However, I think we're in an opportunity when we have the patients in foot clinic where we're actually in a position where we can actually try and encourage their compliance, get those that have fallen off the wagon back on the wagon, and as the gentleman from Ireland alluded to, often patients aren't quite as compliant with what their repeat medication list actually looks like. So taking that time to actually check what they're taking is really important. So for some of my individuals, it means starting them on insulin. For some of them, it will be giving them a Libre to try and engage them to do some better testing so that we can get a better profile of what's going on. But as we know for this patient group, glycemic control is just one of many things that need addressing. So we know that people with foot problems have multiple comorbidities and poor clinical outcomes. And healing the foot for some of them actually is the easy part. We know that the 5-year mortality for this patient group is 50%, and most of those will have a cardiac event. So within my role of the nurse, it's not just looking at their blood glucose readings, it's also looking at their hypertension and their hyperlipidemia, and checking that they're actually taking those medications also, because again, surprisingly enough, a lot of them actually aren't taking what we think they're taking, despite the fact that they're collecting it every month and stockpiling it in the cupboard. The other thing we try and address, which is more challenging, is their weight, because we're asking these individuals to stay off their feet. So we've got lack of activity and increased weight in people that we're trying to keep as stealth-like as we possibly can to take the pressure off their feet. However, what I probably prescribe most of all is antibiotics. And like Jodie alluded to, we're very fortunate we have a microbiologist work alongside us in clinic, which I agree has had profound implications on our clinical outcomes for our patients. And certainly in my journey of a diabetes nurse, I'm now treating patients that would have lost legs, not just digits, some years back. However, when I make those clinical judgments, it can be quite challenging because I may have started something on very simple, flucloxacillin. They come back and the tissue that I sent doesn't show that it's sensitive to flucloxacillin. However, the wound has improved and the patient's doing well. And you're then in that predicament, do I stick, twist, stop, ask a friend, what do we do next? Because the patient doesn't always replicate what we then find with our clinical findings. We also then introduced within our team the use of home intravenous antibiotics because we knew a lot of our patients were systemically well, but their resistances or their tolerances to oral antibiotics were quite challenging. So we decided as a nurse-led service that we would try and work out how we could link in with the home intravenous team to make sure that these individuals didn't need to come into hospital. Because as we know, once they come into hospital, they're in for a lot longer than they needed to be in hospital for because they've got so many other problems that they then become a bit of a minefield. So we decided that we would link in with them quite closely. And that has worked really well. So we have to ascertain, first of all, whether that individual is appropriate for home intravenous antibiotics. And I have become quite, the nemesis of some of the home IV teams when I've sent them into houses that I perceive to be quite clean and pleasant, and they haven't been. We also use home IVs for our dialysis patients, where they then actually don't need to come into hospital, but they'll have their IVs at the end of their dialysis. So as a way of trying to prevent them having to come into hospital. We know that offloading is a key factor, and I don't think there's anyone in the room that would argue that actually CAST is still recognised as gold standard, amongst other things. However, within our trust, several years ago now, the nurse who was our casting nurse at the time, who taught me how to cast, competencies were drawn into question. So as the lead nurse, it was then my problem to sort that out. So the matron came to me and said, are there any national casting competencies? Oh, I don't know. I just do. Very NHS, see one, do one, you teach one. That's how we roll here. We haven't got time for anything else. So through the joy of attending conferences like this, I'd managed to build up a network of people that I knew casted around the country. So it became a little bit like a phone a friend. Have you got any? Do you know of any? Bottom line is there were none. So as a group of keen individuals, we set about writing some competencies. We then decided, as you do, with everything in diabetic foot, to take it to another level and standardise what we called different casting techniques. And then we decided we'd write a casting course. So what started as something as simple, this person's not doing what we think they should be doing, who actually was, became a whole host of work. Quite enjoyable and enlightening, but a big piece of work. So the MDT is something that we've all touched upon so far this afternoon, and the collaboration of the MDT really is fundamental to getting that good patient outcome. Agreeing those care pathways is hugely challenging, and I think as a nurse, I'm probably one of those pivotal people that will be saying, but why isn't this working? Why are we getting these outcomes? Why isn't that working? And pathways are often the reason that that isn't working. So we decided that we would audit our inpatient pathway because our patients seemed to be waiting longer than we wanted them to. And like Nikki alluded to, and Jodie, we're across 3 sites. So we have foot clinic on one site, orthopaedics and admission beds for our inpatients on another site, and vascular on another. So you feel like you're almost coordinating the world at times because no one wants to go left to right or possibly come and see the patient without a bit of to-ing and fro-ing. So everything took longer. So we decided as a multidisciplinary team that we needed to redefine the pathway so that we could optimise the care that these patients got in a timely fashion. And vascular was deemed as the most important aspect there because they could give the antibiotics, which is often what these individuals needed, but nobody else could revascularise them, which was also what a lot of these individuals needed. So we decided that we would then redesign the inpatient pathway to try and reflect this. We're also fortunate enough, and I think you've got one of our vascular consultants talking tomorrow, to jump on the back of the vascular and limb salvage service that was set up. So they did their initial pilot and we said, well, actually, yeah, we want a piece of this. So as our outpatient diabetic foot clinic, we could then refer directly to the vascular and limb salvage service, who would see our patients within 24 or 48 hours. If the angio was then deemed appropriate, it was then done either then or within 7 days, depending on the urgency. And that has had profound implications for the outcomes of the patients that we're actually serving. They don't have to come into hospital to have it done, but we know that they're going to get that service quickly. And then we've obviously also had the joys of the getting it right first time and trying to get some people that don't even like being in the same room to collaborate. So it's been a joy. I think ultimately what drives me and will continue to drive me is being that patient's advocate. And whether that's an extended role or an expanding role, I don't know. But I think the way we communicate with our individuals is really important. Some of them are able to articulate very clearly their wishes, their demands, and what they will and won't do. However, there are those that really struggle. And I think being the nurse who is the constant in foot clinic, they see me as a face that is familiar and that they're willing to share, and sometimes share too much information with, but the barriers that they have to the care that we're asking them to achieve. And that might be as simple as wearing our sexy footwear, going into cast, complying with antibiotics. There's often good reasons why they're not engaging in the care that we're asking them to engage in. I think also for me, it's being that person that has those more difficult conversations. So when more definitive surgery is required, or whether it's going to be conservative treatment. And I think because they know I will give an honest opinion, good, bad or indifferent, they trust it. And I think that is really important. And I think we can't underestimate how important it is that we look above the ankle and actually look at the whole person and not just the foot, because we do become very wound focused and healing focused rather than actually looking at the whole person at times. So I've also had several opportunities that I've taken along the way. So we had a nurse consultant join us in Leicester who was the nurse representative on the FD UK committee, who decided that that was now going to be my job because she couldn't do that. And I can remember trotting off to Manchester thinking it was very important. Sat in a meeting with, again, people that I'd only ever seen on papers that were now real people, and listening to them talk and thinking, I don't really know what they're on about here, because everything was an acronym that I had to work out, and then they got to another one. So before I could put the sentence together, I'd not quite worked out the first one. So I went home with a notebook of acronyms that I was going to learn, so the next meeting made a much more sense, which thankfully it did. I was also the nurse representative on the NICE guidance for the diabetic foot, which again sounds probably more grand than it is, because there's not that many nurses that are keen on the diabetic foot, so I don't think there was too many names in the hat on that one. But one thing it did teach me was that a lot of what we do isn't based around good randomised controlled trials. It was interesting, Andrew, saying sort of earlier on that we're now getting some of that robust evidence to actually back up what we're doing. And I think even doing the National Diabetic Foot Audit, it's proven what we already knew. But without that evidence, we couldn't actually say that what we believed was happening truly was happening. We knew that late referrals didn't do well, but we've got no evidence to back it up. So I love what I do clinically. However, I do get one day out a week where I go and do some education. So I work with the Eden Diabetes Education Team in Leicester, and I get to educate healthcare professionals around all aspects of diabetes. Needless to say, my passion kind of swings a little bit one way, and I feel quite fortunate that I've been able to then embrace the primary care team to get them to understand the referral pathways, who to refer, when to refer, how to refer, antimicrobial guidance, so things are started sooner rather than later. And I think that ultimately has made a big impact on who we then see in clinic, because a lot of them will have already had antibiotics initiated and referred after that first lot, rather than 3 or 4 lots of antibiotics down the route before they actually end up in clinic. And my biggest thing would be, my mum would always say to me, take every opportunity that's offered to you, because you only regret those that you don't take. And I think it's really true. I think there are things that I've been sat in, part of, and I've thought, I haven't got a clue what's going on here, but I'm going to do my best to work it out. I'm certainly not a natural academic, but I've embraced it, I've enjoyed it, and learnt a lot through doing it. So I am a nurse with enhanced skills, I can assess a patient, I can sort their medications out, I can debride the wound, I can dress it, I can do their imaging, I can review it, I can cast them. But actually, as one person, that's never enough. You need to be part of that team to get that inspiration, that motivation to continue to learn. And whilst I have lots of skills, they're not all needed all of the time for every single patient. And I think it's really important that we lead by example, and those good examples really then should shine through. Thank you.